Basic rehab exercises for the foot, ankle, and lower leg. So we've gone over how to assess, we've gone over anatomy, we're going to talk about injuries when we do the projects. Now, how do you fix those injuries? So basically, we need critical and incorporate appropriate rehab techniques. That matters because the foot is the basic support for the entire kinetic chain, and if your foot is messed up, it's going to affect your biomechanics, and it's going to affect your knee, your spine, your hip, like all the way up the body. We want to make sure that we are maintaining cardiorespiratory conditioning. So using a stationary bike or arm bike or swimming, this is how we continue to have that even when we can't use their feet. You have to make sure their endurance stays up and their upper body stays strong. That way they're ready to go once their lower limb is ready to go. Weight bearing. So immediately after injury, most of the time there's a period of maximum protection, meaning partial weight bearing or non-weight bearing, typically on crutches or wheelchair or scooter. There's different options. After surgery or injury, you want to limit the stress initially in the inflammatory phase to promote the faster healing. So therefore, we try to put them on crutches to help control and decrease the complications in the healing process. Incorrect gait mechanics can also affect other joints. So therefore, if they're walking with a limp or doing something strange, it can affect their other leg or their hip or their knee. So you want to make sure that they are walking correctly when they are able to. And if they're not able to walk correctly, you need to put them on some type of partial weight bearing or non-weight bearing apparatus, i.e. crutches or scooter or wheelchair. Crutches. When you want to fit crutches, you want to make sure they're in proper shoes and on like shoes without a heel. The tip of the crutches, so the bottom of the crutches, should be about 6 inches away from the outer side of the shoe and 2 inches in front. And then you want to go up to their armpits and then about 2 inches or 3 fingers below the armpit. What chronically happens is people want the crutch all the way up into the armpit. You don't want it there. You want it about 3 finger lengths below the armpit. If it's up in your armpit and you put all your pressure through your armpit, you're going to have your arms and hands go numb because that's where all your nerves and arteries are. So the reason for this is your strength, and when you control the crutches, are from your triceps. It's not from your armpits. You use your armpits to just kind of hold it steady, but all the force should be through your triceps and into your hands when you are using crutches. Therefore, you need to make sure the hands are in the proper placement. So about 30-degree angle of the elbow, and that's where you want to put the hand grip. So when they're non-weight bearing, they stand on the uninjured leg, and they want to crutch first forward, and then you hop too. You can't hop past it until you get more consistent with it and more comfortable with it. However, you want to keep it logically within the box of the crutches, because if you crutch too far forward, you're going to lose all your stability and your balance. Crutches and the injured leg are always going to move together. That's how you know where to go. When you're dealing with an injury, one of the first things you want to do is flexibility, and joint moves are a good way to maintain that range of motion or get that range of motion back. There's different techniques depending on the structure of the joint, if it's a convex or concave, or depending on what it is. So a couple options are anterior or posterior tarso-metatarsal glides that help with mobility of the metatarsals, or anterior-posterior MTP glides. Anterior increases extension and posterior increases flexion, and you use individual isolated segments. So looking at this, so right there, tarso-metatarsal glide. So they're working with the tarsals versus the metatarsals, and we're trying to slide them against each other and pull them. And it's quick, short movements, and it's like you're pulling and relaxing, pulling and relaxing. Metatarsal glide. So just like, I'm sure we've all pulled our finger and you kind of feel that tension or that pull sensation in your joints, and it's a little bit of movement. So you pull, give a little traction, and then you go anterior or posterior depending on what you're trying to do. There's the same concept for the ankle for dorsiflexion or plantar flexion. So plantar flexion, if we want to increase that, we're going to do posterior tibial glides and anterior talar glides. Dorsiflexion, we're going to do anterior tibial and posterior talar. To increase inversion or eversion, we're going to work with the subtalar, medial and lateral joint glides. So anterior and posterior glides. So we hold one portion of the tailcrural joint steady, and then we're going to push the ankle or foot through either anterior motion or posterior motion, depending on what we're working on. And like I said, you're pushing to the point of resistance and relax. This is basically a step below like a chiropractic, like snap, crack, pop moment. We're not doing it. So here's subtalar for medial and lateral. So for inversion, eversion, same exact concept. You're stabilizing one part, and then you're going to push on the part that you're working on. So medial or lateral, depending on what we're working on. So the force goes through, and like I said, it's short, quick isolations where it's, push it, relax, push it, relax, push it, relax. So like I said, maintaining flexibility is crucial and critical to get back to play faster. So one of the quickest, easiest things to do is work on this in stretching. So we want to make sure we're stretching the plantar fascia, the gastrocnemius, any type of lower leg area. We want to improve range of motion with plantar flexion, dorsiflexion, so towel stretching, standing. We want to perform exercises slowly and without pain, but we want to perform them as best we can. Also, like the alphabet is a good way to work on inversion, eversion. I'll show you specific exercises a little bit later. So when an injury happens, one of the first things to lose is neuromuscular control. So muscle weakness and proprioception deficits basically prevent the athlete from being able to balance. Proprioception is the concept of you're aware of where your body is and you're able to react. So if anyone sprained their ankle before, one of the last things or hardest things to maintain is that balance component. So if you can get the balance back, then you're ahead of the game. So we really want to focus on that, on the proprioception, because the proprioception is how the body reacts to a change in surface. So if you step on something wobbly, is your ankle or foot able to react and correct and not injure itself? That's what we're trying to do. So these exercises are incredibly important in prevention of future injury as well as strengthening current injuries. So when we're doing this, we want to look at walking and running and hopping and changes of direction and variety of surfaces. So examples are balance board, wobbles board, foam, dynadisc, Bosu balls. We want to start with a double leg stance with your eyes closed, progress to single leg stance with your eyes closed, progress to unstable surface, to stable surface, unstable surface. So basically, these are the progressions that you're going to take. You need to work on range of motion, you need to work on proprioception, and you're going to go from easy to hard. Easy is a double leg stance on a super hard surface. Hard is a single leg stance on a super soft surface or unstable surface with your eyes closed. Depending on what we're working on or what stage you're in is where you're at. When we talk about closed kinetic chain, that's when your foot is in contact with a surface. So it's closed. So like a leg press or a mini squat. An open kinetic chain is when it's not planted or have a surface contact. Therefore, you're at more risk of injury in an open kinetic chain versus a closed kinetic chain. Muscular strength. So there's a million different ways to do muscular strength, and this is when you get to be creative and figure out what you want to do or how the athlete wants to work. You can do isometrics, where an isometric, remember, is no movement in the rehab phase. So that's when early rehab, so you're pressing against a surface. So your range of motion is not changing, but you're working on that contracture of the muscle. You can do tubing, towel, manual resistance. There's a lot of things you can choose, and nothing's better, nothing's worse. It's what works for you and what works for your patient. What limits it is pain. The point is not to be in pain. So some common strengthening exercises are writing the alphabet with your toe, basically working on that range of motion. Picking up objects like marbles with your toes and putting it in the cup. You would think that's super easy, but when you've had an injury, that can be incredibly difficult. Literally just doing ankle circles, forward and back, up and down. gripping and spreading your toes, working on that range of motion in your toes. Towel gathering, so scrunching up the towel or putting even a weight at the bottom of that towel, so when you pull on the towel, there's a little resistance. You can also rotate the towel and do inversion, eversion scoots. Here's another example of that, where you keep your heel planted and you rotate out. For eversion and inversion, you rotate in, depending on what you're working on. You've probably all seen TheraBand or tubing, and so you can use it for the toe, you can use it for the ankle, you can use it for all different body parts. Isometric plantar flexion, so notice there's no change in angle, you're just pushing against something. Dorsiflexion, you're trying to push your foot up, but you're not changing that range of motion. Inversion, eversion, you want to work on strengthening that way. You can use hands to give resistance. You can use the tubing like I showed you. Like there's plantar flexion, dorsiflexion with tubing, as well as inversion, eversion with tubing. Taping and bracing. So a lot of people like to have some type of support as they're coming back from injury. It is a good thing to have. Some people, depending on the topic, depending on the person, depending on the sport, sometimes we tape to prevent and sometimes we tape after injury. It just depends on the situation. Tape does have a stabilizing effect on unstable ankles and it can protect injured ligaments. However, taping does loosen up after about 10 to 15 minutes. So it's not as effective after a short period of time. Ankle bracing is more functional and allows more stability and proprioception, and you can tighten it when things loosen up. So a lot of times taping is the preferred older school method, but in reality, ankle bracing is a better option. It's more cost effective in the long term. Tape is expensive. Braces are expensive too, but you only have to buy one. So I recommend bracing to all my athletes. However, I know a lot of my athletes won't wear them because they say they're too bulky. They restrict them. They don't fit in the cleat. There's all types of reasons for it. But I recommend ankle bracing if they're willing to do it. So we have an injury or they're going through the rehab process. How do we know when to progress them or a functional progression? So they're going to go from partial weight bearing to full weight bearing. Then when they're doing full weight bearing, there shouldn't be a limp. Then once they can walk, then we can start jogging. Once they can jog, we can start hopping. Once we can do pool running and hopping, we can start progressing. Pool is an awesome option for lower extremity because it takes a lot of the pressure and weight off. So a functional progression could simply be going from walking to jogging, to walking the curves, to jogging the full track, to running for fitness, to lunges, to sprints. Deceleration, acceleration are going to be one of the last things to do because it's that stop and start that hurts the most. Side shuffles, karaoke, skipping and jumping, those are the last things. So cutting and like change of direction, those are at the end. So initially you can only run straight ahead, you can't cut or something to that nature. But once you get past that, then you can add to it. So to return to activity, patients need a complete range of motion, and they need at least 80 to 90% of their pre-injury strength. So they need to be comparable in strength to their other foot, and they need to have been able to go through that full functional progression and be able to participate in their sport to the fullest extent. There shouldn't be a noticeable difference in their participation or their ability to participate if you are allowing them to compete.